Okay, so in general terms, we're starting off with a normal cell. That cell, of course, it's possible that it has, we have inherited some mutated versions of genes from our parents. So there's always a possibility. Even if it's just one copy and we have a backup copy and we're dealing with a tumor suppressor gene, we're still in a situation where now life is a little more precarious because we only have one functioning copy. We don't have a backup anymore. Okay? So we start off with a normal cell and we endure some sort of DNA damage. Hopefully what happens is our DNA repair mechanisms, we have a lot. Nucleotide excision repair, base excision repair, etc. Double-strand break repair. Hopefully gets to it and fixes our damage. Okay? But if we have a failure of DNA repair, then we're going to have mutations in the genomes of our somatic cells. So say, for example, you've been out in the sun too much, it's lovely and warm, it's not good for you. Okay? And we've had DNA damage as a result of some pyrimidine dimers and other things like that. Say we fail to fix that, so we actually have mutations now instead of just DNA damage. Okay? So we could have, as a consequence of that, we could have mutations that activate a proto-oncogene to become an oncogene. Okay? So now we've got our accelerated petal down on the floor for cell division. Or we could have inactivation of a tumor suppressor gene. So you inherit one bad copy from mom and dad, and now this hits the other copy. You have no functional copy left. You don't have, you're missing breaks. Or genes that regulate apoptosis or DNA repair. And so this is going to result in excessive cell proliferation, so unregulated cell division, basically, as well as quite potentially decreased cell death, decreased apoptosis. So we start to have proliferation here. Okay. Anytime you have a situation where where cells are dividing faster, okay, just by virtue of it's just a numbers game. You always run the risk of having additional mutations. Okay, you're cycling fast. You run the risk of having additional mutations. Okay, and so we start to build in some genetic diversity here. So we could have additional mutations that result in acquisition of the ability to build new blood vessels, so the tumor can grow. Escape from immunity. Additional cell growth. Lots of different options at this point. And so the tumor starts to progress. It becomes a larger tumor first, and then once it acquires that ability to kind of have cells either escape into the lymphatic system or escape into blood vessels and move to other sites around the body, if it has the ability to stimulate the growth of new blood vessels, it can set up new tumors and new sites. And that's where we've made that real jump from having a benign tumor to having a metastatic tumor, a malignant tumor. Okay, so that's kind of a brief overview of sort of the sequence of steps. I'm going to talk in a little bit of detail with reference to a few genes with respect to colon cancer, just because it's well defined. Okay, so like I say, cancer's a multi-step process. That's the general view of things. Anyway, is that you require some sequence of steps, 4 steps, 5, 6, 7 steps for this to happen. And this is these are not the steps themselves. These are what's happening at kind of just at the level of cell proliferation or the cells in terms of their journey to becoming cancer. We'll talk about the steps in a second. I just wanted to talk about the sequence of events from the kind of cell division and cancer perspective. So we start off with some normal cells. Kind of the first event is usually something that stimulates cell growth, so we just have dividing of cells. The cells are not cancerous. They're just dividing too much. Okay? And so we have what we call hyperproliferation. In the colon, we call this a polyp. Okay? Usually a hyperplastic polyp. Okay? So just a lump of cells, too many cells. Okay? We have some additional events. So we start to lose additional control mechanisms on our growth. Then we can form, I always struggle with saying this, a adenoma. And at this point, we certainly formed a precancerous polyp that would be excised, often in conjunction with colonoscopy. If we lose additional controls and we start to actually invade, so we start off in the mucosa, but if we start to actually invade the underlying musculature, then we become a full-fledged carcinoma. If we access blood vessels or lymphatics, both of which are available in the submucosa below the mucosa in the colon, then we can start to spread around the body and set up shop in other locations. And now we have a fully fledged metastatic cancer. Now there are gene mutations that are associated with our steps along the way. And this is why I like talking about this particular cancer, just because it's pretty well defined. Okay, so now this is kind of the same picture here with a bunch of gene names. And I'm not trying to give you the whole gory detail on this, because like I say, it's really the work of weeks, not hours here. Okay, so usually what we call the gatekeeper gene is a gene called APC, for adenomatosis polyposis coli. I won't spell it for you. Okay. Basically, its job is to keep cell proliferation under control. It breaks. Okay. You lose both copies of APC. You stop being able to suppress cell proliferation in the crypts in the colon, and cells start proliferating so much, and you end up with a polyp, hyperplastic polyp. Okay. Then, because you're dividing so much, you run more risk of having mistakes. Okay, so you could have a mutation affecting RAS. Now, RAS is a proto-oncogene. Okay, well, we need only one copy of it to become excessively active. And basically, what it does is have further impact on processes regulating cell growth. So it makes the problem worse. So we go from being a kind of a small polyp to being a larger polyp. Then there are other mutations along the way. One of the big players here, so I'm not going to talk about DCC, because actually its role is a little bit vague. SMAD4 is another one that's probably a better example. But I'm going to talk about P53. Okay, so we've kind of talked mechanistically about what's going on with P53. With P53, its job is to respond to DNA damage. You lose P53, another tumor suppressor, and you stop halting the cell cycle when there's DNA damage. You don't stop to fix it. And you don't prompt the activation of the DNA repair processes. Mutations start accumulating badly, quickly. This is where you have that clonal expansion, where you end up with, instead of one sort of cell type in there, you end up with multiple cell types with different properties, different mutations, different responses to chemotherapeutic agents and things like that. Now we're in big trouble. Okay? Now we can become a full-fledged carcinoma. Okay? And then, assuming that we have, for example, again, the ability to prompt angiogenesis, promote angiogenesis, then we have cells that can move to other locations, build donor blood supply, and set up cancers elsewhere. Okay, so it's really excessive cell proliferation, loss of additional genes so that the tumor can grow, or the precancerous polyp can grow more correctly. And then you lose one of the major players, like something like P53. You stop fixing the DNA damage, mutations snowball. Okay, and you end up with these genetically heterogeneous tumors. Does that make sense? Okay, so that was like cancer in 2 slides. Okay, so want to talk about kind of, again, some general truths about cancer. Now that we've kind of talked our way through a bit of a cancer development pathway, the road from just simply excessive cell proliferation all the way to having a metastatic cancer. Okay, so neoplasia is basically just new growth, right? Producing, in many cases, billions of new cells. Okay? So we have this abnormal tissue now, this growth. Okay? And one of the things that I'm trying to stress here is we may have started off with one cell with a particular genetic defect, like an APC, loss of both APC genes, right? But along the way, especially with the loss of genes like P53, we've accruing mutations. And so our family tree looks more like a hedgehog now, right? Because it's just all these different branches that have shot off in different directions. Different mutations, different subclones of cells. So this real heterogeneous mass of cells now, which raises real problems when we try to tackle it. Because not all those cells are going to be responsive to the same things. Some of them may already, before treatment, be resistant to particular treatment modalities. Okay, so it looks different than the surrounding cells, so different sort of texture and things like that. That kind of, we'll talk about this aspect of differentiation in a sec, but it looks different than the surrounding tissues. So histologically, morphologically, etc. So it's gained its ability to ignore the normal constraints, right? It no longer requires positive reinforcement through growth-promoting pathways, and it's able to ignore those pathways that would normally suppress growth. So it's able to replicate without any kind of concern for normal controls. Differentiation. Okay, hopefully, so differentiation is the acquisition of a particular cell identity, right? So everything starts off as a stem cell of some sort, and then through the selective activation or repression of specific genes, becomes some sort of terminally differentiated cell eventually, right? So skin cell, muscle cell, whatever the case may be, with particular characteristics. Okay, cancer cells lose that; they de-differentiate. So you could have, for example, a cancer cell. The nice example is this. So fat cells. You ever looked at the fat cell under a microscope? They look like honeycomb. They've got this big central globule of fat. Okay, and the cytoplasm and nucleus are squashed over to the side. Okay, if they lose that characteristic appearance of fat cells, they have de-differentiated. Okay, they no longer resemble the type of cells that they were derived from. They've lost that. Like I say, some cells do have a kind of definite genetic inherited genetic component. They are familial cancers, but honestly, those are the smaller set. Okay, the ones from sporadic causes are by far the largest set. So we kind of guesstimate maybe 70% are from environmental causes, what I refer to as the sporadic cancers, as opposed to the familial. Okay, so fail-safes on the system. These are things that normally kind of prevent cancer. Okay, and these are often things that get disrupted in the process of cells becoming cancer. So I touched on DNA repair mechanisms. Okay, if you can stay on top of the DNA damage, that's a big part of preventing cancer. All those XP genes, the things that fix double-strand breaks, pyrimidine dimers, et cetera, et cetera. Okay, so we have those pathways. Apoptosis and senescence. So apoptosis programs cell death. We can funnel cells into that when they start having DNA damage that we can't fix. Or senescence, once cells reach a certain point, they naturally die. Okay, why is that helpful? Well, because after 50 generations, the chance that we start accumulating mutations just becomes higher. It's better to have cells, sorry to put it this way, that are 2 generations old, not 50 or 100. And then there are physiological or anatomical barriers. So basement membranes, for example, are membranes that sort of separate different tissue types, right? And they represent permeability barriers, amongst other things, and physical barriers. And so, again, they kind of keep things kind of sequestered off, okay? But if you are a cancer cell and you start expressing metalloproteases and you're able to eat your way through a basement membrane, then that is no longer an issue. And then, of course, I mentioned our immune system. Busy flagging aberrant cells. How they identify them? Sometimes through those aberrant proteins that are expressed in the cell surface, aberrant receptors or other things like that. Okay. Part of, and this is beyond what I'm talking about today, but you will probably in the course of this course, or if not on site, you will learn about immune modulators and things like that, where we try and get our immune system to do a better job, and that can be utilized as an adjunct therapy in cancer as well. And try and get them to flag themselves. Yeah.
And you might go to this later, but what do cancer cells, I don't know, do they put something on their surface that makes them not able to get recognized by our immune system, or do they not show anything?
Yeah, a lot of times they just manage to not show. Those cells that do display abnormal proteins on their surface get flagged by our immune system, but those that don't tend to fly under the radar, so it's mostly about that, being able to fly under the radar. Most of them do get flagged. Like I say, 99% of them do get flagged, but there's always those fraction that don't display anything obvious that allows them to kind of elude detection.
Okay.
So it's really more that than anything else. There are probably more sophisticated answers to that, but I'd have to kind of say that would be the limits of what I would be able to comment on. Just a quick comment statistically, so cancer is about 1 in 5 individuals, okay, during their lifespan, okay? And actually, so for certain cancers like prostate cancer, so for every male in the room, if you live long enough, you will die with prostate cancer, okay? So most individuals when they reach a certain age are going to get prostate cancer if they live long enough. It's just kind of almost inevitable. Okay? They will probably die with it rather than from it, but there's a very high likelihood. Okay? We've made some inroads, of course, in terms of we've made some inroads in terms of treating cancers and improving outcomes, but unfortunately, you know, you win some and then you also are losing some. And some of the places that we're losing some from is so things like intravenous drug use, increasing HIV. Not that this is a really recent phenomenon, but that has also increased cancers that tend to be spread along with HIV. So Kaposi sarcoma virus is a virus that is often co-transmitted. It's actually a sexually transmitted disease that's often co-transmitted with. So the kind of cancer that often co-segregates or co-transmits with HIV. And then, of course, HPV and other things like that. So while we've got better at curing cancer, societal practices and that have sometimes kind of undercut some of our successes. And so, in particular, things like some of those sexually transmitted viruses, HPV and others, that we could probably be doing a better job with. And so we've gained some ground and lost. Okay, and this is just a quick comment. This is kind of interesting. I wanted to keep this in here because it's just kind of interesting. So what we eat and what we're exposed to, of course, has a huge impact on risks of cancer of different types. And so it's just kind of interesting to compare. So, you know, there's certain food that are kind of culturally the norm in certain countries. So this is kind of interesting. So in Japan, stomach cancer is quite prevalent. Prostate cancer, really not. And so if you take Japanese immigrants to California, for example, they tended to more or less eat what they were culturally kind of accustomed to. And so their cancer patterns stay fairly similar. Okay. The interesting thing is that we become progressively more like the kind of normal California pattern as they stay longer because they start adopting the kind of cultural norms in terms of food and everything else that they're exposed to. And so very quickly they actually sort of look like Caucasian individuals from California as well. So there's a large impact on cultural norms, you know, what's kind of food. So Japanese diet is generally relatively low in fat, high in fish, and things like that. And so that has an impact, but of course the California diet isn't necessarily. So certainly the average American diet isn't nearly high enough in fish. So the point that I want to make about this is just how cultural impact practices and traditions and food consumption and dietary patterns and that's kind of impact our susceptibility to different kinds of cancer. So the main thing is just don't eat anything. Yeah, the sad truth, sorry, a little segue. The sad truth is if you, there's very few doctors in the world that will say eating a bunch of green vegetables is bad for you. So eat lots of veggies. That's about the only thing I've been able to tell after 50 years of it. Okay, nomenclature. Sorry about this. Lots of nomenclature. I added a few points in red kind of after I sent the PowerPoint to Nikki, so just a few minor points there. Okay, so malignant versus benign. Okay, so it's based on appearance and behavior. One big aspect of that, okay, is appearance. Okay? If you take a biopsy of a benign tumor, the tissue tends to look a lot like the normal tissue. Okay, lipomas. If you take a tissue slice from biopsy from a lipoma, it's derived from fat cells. They look like fat cells. They have a central fat globule, etc. So from a morphological perspective, like cell morphology and organization perspective, they look like them. I can see Destiny kind of squinting at my tiny font.
I'm still fine with glasses.
Welcome to my world. Wait till you get 50 and then you'll be like,
I'll be blind.
I need size 24 just to read it. Okay, so they've got normal morphology, normal chromosomes, normal chromosomal content, and normal chromosomal banding patterns, so they're not missing pieces, translocations, etc. Slow growth, they don't leave the normal site. Okay? So they may have some slightly abnormal characteristics in terms of their fact that they're growing more than they should, but by and large they look like the cells they were derived from. Malignant tend to have lost those host characteristics. So host cells that were derived from fat cells no longer look like fat cells. Okay? They've lost that differentiation. They have de-differentiated. They also have abnormal mitoses. So when you look at the cells, so first of all, you're going to see lots of mitoses in the cell. So there's going to, or in the tissue, excuse me. You're going to see lots of dividing cells, which is not necessarily typical for the tissue, depending on the tissue. You're also going to see some abnormal ones that have abnormal numbers of chromosomes, things like that. Okay. One of the things you tend to pick up on is just a pigmentation difference. We call it hyperchromatic nuclei. And it just reflects the fact that the cells are dividing more and they have more condensed chromosomes. It's easier to see all those dark nuclei. And they're fast growing and they're invasive. And of course, they're generally, if not metastatic already, at least they have the potential to do so. So kind of the take home here is they look quite radically different from a chromosomal perspective and from a cell biological perspective, histological perspective. Okay, metastasis. Spreading to non-contiguous points. So this is not invasiveness of surrounding tissues. This is where you have cells break off into the lymphatic system or blood vessels and spread to different distant sites, non-contiguous sites of the body, set up new blood vessels, set up new tumors. Oops, sorry about that. And there's lots of different ways that this can happen. So you can have lymphatic spread, you can have blood vessel spread, you can have transcelomic seeding, which is basically just means when you have a body cavity and cells break off, they can spread in the body cavity. That's all that means. You can have traumatic seeding, which is basically, there's a small risk associated with biopsy. For example, when you're taking a tissue sample of a cancer, there's always a chance that you actually can sort of liberate some cancer cells and permit them to spread. Okay, so it's, you know, it's a risk with anything, but it is a possibility. So you can have traumatic seeding as well. Carcinoma in situ, just really quickly, just means it's kind of a precancerous situation. So by definition, not malignant. So it basically hasn't penetrated through the basic membranes, etc. We'll get to the terminology down the road, so I'm not going to belabor that at this point. Hyperplasia, I've already kind of touched on that. That's just an increase in cell numbers. So an example, colon polyp. Hypertrophy, increase in cell size, okay, sometimes a consequence of changes in cell metabolism, gene regulation, etc. Anaplasia is that loss of differentiated state. Okay, so the cell doesn't look like it belongs to that tissue anymore. It's become, if you want to think about it this way, more akin to a stem cell in an undifferentiated state. Okay. Dysplasia, okay, is basically expansion of immature cells, so undifferentiated cells. There's a variety of characteristics. You can kind of read those there, but you have sort of examples that are variation in cell shape, cells that are unequal in size. So blood RBCs, for example, pretty systematically the same size, roughly, right? But you can start to have differences in the population. That's not a good thing. Okay. Mitotic figures are just dividing cells. Okay. And hyperchromatism, like especially hyperchromatic nuclei, is often indicative of just more increased cell division. It's basically a darker nucleus when you do histological staining. Metaplasia is actually kind of more of a precancerous kind of thing. So Barrett's esophagus when you have reflux. Okay, so you're stressing the cells, and you have changes to the cells that become basically to a different type. So you have some adaptation to a physiological stress of some sort. Okay, it can, in some cases, lead to dysplasia and use of angioplasty. But it's not at that point a cancerous condition. Okay. I wanted to talk a little bit about invasiveness, okay, metastasis. Okay, so we kind of started off with, again, this is kind of hitting on some of the points that I sort of hit on earlier, but I'll try not to belabor it here. So let's assume that we have This is an epithelial cell there. So it looks like we've got some squamous epithelial cells. At the top there, we've got a basement membrane underlying that. And so we're probably generating new cells from the bottom and slough off cells from the top. That's normal. Then we can end up in a situation where we have hyperplasia. So again, akin to the epithelium of the colon, where we have colon polyps. Then we can have carcinoma in situ, where we essentially just not invading into past the basement membrane yet. So we're still in the original location. Then finally, you have an invasive carcinoma. You made your way through the basement membrane. If you have access to blood vessels, you may start entering blood vessels of the lymphatic system. And so now you can move around the body, potentially set up shop elsewhere. Okay. Now, in way too much detail. Okay, I'm just going to kind of make a few points here, rather than I'm going to kind of leave it to you guys to kind of live through this, because it makes kind of the same points, more or less, that I just made. So we had our original events. So we had our initial mutations where excessive cell proliferation, diversification from a genetic perspective, a big ability to stimulate blood vessels. Like I say, our tumors are not getting above a certain size without the ability to feed those innermost tumor cells, which requires building new blood vessels or stimulating their new growth. Then you have a metastatic subclone, so some subset of those are able to move their way through the basement membrane, for example, penetrate through, eventually get into blood vessels or the lymphatics. And so there's a couple possibilities at that point as we spread throughout the body. So those subclones that don't have angiogenic possibility may be able to set up somewhere else briefly, but they're only going to make teeny tiny tumors. Okay? Those that have angiogenic potential will set up in those new positions, stimulate blood vessels, and grow. And so we have these events called introversion, extravasation, intravasation and extravasation, which is basically the point of kind of entering into the blood vessels and then being able to pop back out of them and move into other tissues. So I kind of said that already, but it's just got a little more detail. So I won't kind of go through it. Okay. Again, I'm going to leave a lot of this to you to kind of look at in terms of nomenclature. Okay, so generally OMA is a term for kind of neoplastic process. So we have non-neoplastic OMAs. So lipomas are benign tumors. Okay, hematomas, granulomas, etc. So they're benign tumors. But often you'll see this in the context of, for example, carcinomas or sarcomas. So the basic distinction here is carcinomas are epithelial cells. So those, even the colon cancers are derived from epithelial cells, skin cancers, etc. Okay, sarcomas are mesenchyme derived, so muscle underlying tissue. Okay, and I'm just going to kind of leave the rest of it for you guys to kind of look at the nomenclature that you should become familiar with. Okay, and again, I'm definitely not going to belabor this. I do want you to know it though. Okay, but I'm just going to, yeah, we'll move on. Okay, look at it on your own time. Okay, you can memorize this. No kidding. Okay, this is just, again, you should kind of be aware of the malignant and benign terminology here. Okay, so you could have, for example, a lipoma versus a liposarcoma. What's the difference? If you look at a lipoma, it looks like a fat cell. If you look at a liposarcoma, it does not. Okay, it's that characteristic loss of differentiation and metastatic potential that makes the difference. Okay, but definitely become familiar with the nomenclature. Okay, so consequences. Okay, so even benign tumors can have consequences, right? So for example, both benign and malignant can have consequences just by virtue of their position. So they can press on something. So you could have effects on the heart, effects on lots of tissues. So Barrett's lymphoma has effects just by, one of the things they found was that you couldn't even biopsy it because it put so much pressure that you had patients dying on the table when they were being when they were being anesthetized. The weight of it would compress the basically lungs and stuff, they'd suffocate, right? And so you can have consequences that are more due just to kind of position and mechanical effects than anything else. Obstruction of airways, things like that, or passages or other things like that. So you can have kind of both consequences at the anatomical and local levels that are more just a consequence of the fact that we've got a large massive cells there. Okay? You can also have systemic effects. So you can have, for example, the obvious ones are things like pituitary tumors. So ones that, for example, produce excessive or excessive release of growth hormone. So anyone watch The Princess Bride? Okay? Andre the Giant, right? So he had suffered from an untreated pituitary tumor that resulted in excessive release of growth hormone. And so he had acromegaly, and so he continued to grow. And so it has a lot of consequences in terms of his health, which is why he died at a relatively young age. But it would be just kind of a convenient example to remember in terms of having an effect at a systemic level from the release of excessive growth hormone. Fortunately, people have gotten much better at recognizing when that's becoming the case. There was an interesting example that I became aware of with the identical twin set, where one of them acquired a pituitary tumor and ended up about 2 feet taller than the other one, but eventually they got on top of it, and they thought that the twin that was not growing was suffering from a kind of failure to thrive kind of issue where he was not growing. It turns out he was the healthy one, and it was the twin brother who they had not paid enough attention to, who was growing furiously, who was actually the one who had a problem. And so they corrected it. He did end up literally about 18 inches taller than his identical twin brother. Yep, so just think Fezzik from Princess Bride. Okay, again, this is a helpful thing to kind of just acquaint yourself with. So these are some direct systemic effects of neoplasia. The reason that it's kind of helpful is one of the major issues that you deal with as a clinician is, so cancer is kind of a great imposter, right? You have these symptoms that are often big and are often ascribed to some other medical condition. You end up with a lot of people who present because they've got something that they think is some sort of bowel irregularity or something like that that presents some other problem, and they eventually figure out what the actual problem is. And so it kind of mimics a lot of diseases. And so the symptoms are often vague, and it's just kind of helpful to keep them in the back of your mind. And so, things like you can have so bone invasion and destruction, so pain and fracturing of bones and things like that. It may not be obvious when it presents that it is actually being caused by cancer. And so I don't want to kind of belabor this, but I would recommend you kind of take a look at it, just in terms of just kind of bearing in mind some of the symptoms that can result from these tumors impacting the body parts that they're affecting. Okay, let's talk causes then, real quickly. Make sure I'm doing okay for time. Sorry if I keep blabbing on here. I'll try and stay on task here. Okay, causes of neoplasia. Okay, so kind of it boils down to these 4 categories here. So carcinogenic chemicals, okay, and there's lots of them, okay. Radiation, so every time you go outside, okay, but also all those medical x-rays, dental x-rays, things like that. They come with a cost-benefit thing, but, every time you're exposed to radiation. Viruses, HPV, okay, 35,000 cases of cervical cancer every year, at least 29 to 30 of them vaccine preventable, okay? Huge cause of cancer, okay? And then not to mention esophageal and penile cancers as well. And then inheritance. We'll kind of walk through those kind of quickly. Okay, so carcinogenicity of chemicals. So it's kind of dose dependent, so the more that you get exposed to, the higher your risk. And it's also kind of summative because small, multiple exposures can be just as bad as one large exposure. Sometimes you can have kind of synergistic interactions between chemicals that can become problematic. There's some effort to kind of stay on top of some of this through things like the Ames test that you learn about in microbiology. where in some cases they'll take actually bacteria and they'll assay the chemical for the ability to cause mutations in bacteria. Sometimes they will even treat the chemical with a liver extract first to kind of mimic what would happen if that chemical was metabolized by the liver, and then they'll expose the bacteria to it. So you can do things like that, but it's still hard to get everything, okay? Which is why so many things that we end up finding are carcinogenic. Take a long time to be exposed as such. So for example, Roundup in Europe is considered to be a carcinogen. You don't use it over there. Probably most of us, or our parents at least, have a Schwitz bottle of Roundup to get rid of those weeds in the sidewalk and stuff like that. Okay, metabolism has a huge impact on this. So your ability to metabolize a particular chemical, so age, sex, nutritional status, and things like that have a huge effect. So in terms of how we kind of think about chemicals sort of playing into this process, so we have initiation events. So we have chemical initiators that produce permanent damages and permanent damage to DNA. So they induce mutations. So they cause things like double-strand breaks, alkylation, methylation, well that is alkylation, and they may also impact DNA repair. And so these chemicals that induce DNA damage are obviously those kind of triggering events to produce the mutations that instigate the development of cancer. My little comment about damage must not prevent itself from replicating is that this has to fly under the radar, right? If it induces enough damage to halt a cell cycle, prompt P53 to do its thing, or to trigger apoptosis, then obviously that's our kind of preventative mechanisms. So this has to be kind of damage that flies under the radar. Promotion, so we've kind of initiated some of the early processes. So for example, the sort of hyperplastic situation, excessive cell proliferation. And so this is basically inducing those subsequent changes, okay, the more downstream changes. Conversions, basically cells no longer require sort of promoters for proliferation, so they're on their own, basically. And then progression, you know, when we get to mutations in P53, for example, and we start having enhanced genetic diversity in our group of cells, we have more mutations happening, and we sort of have all this diversity in the subclones, which makes life difficult for us to treat. Not only is it kind of a battle between different cells within that tumor for which is the most successful, whoever grows the fastest becomes the most successful. Okay? So there's that kind of battle between their neighbors. But it's also when we try and intervene by using chemotherapy and try and disrupt this process, if there's a subset of resistant clones in there, then those clones are going to become the predominant cells over time. And so we'll have a hard time tackling that. And that's a really common thing. That's why we use combination therapy so much. Okay, and just a couple nice, well not nice examples. I just wanted to point out two quick things. So asbestos, some mesothelioma. Okay, basically what's happening is asbestos gets, you inhale the particles of it, and it causes inflammation and scarring, excessive cell proliferation. And then you may have mutations in those cells that get transformed to become neoplastic. You can also just want to point this out, and the extra arrow there was one that wasn't in your version of it. Pointing out the fact that anti-cancer drugs, okay, are actually cancer-causing drugs, too. Okay, so it's a fine line. Okay, so many chemotherapeutic agents, alkylating agents, for example. Nucleoside analogs are mutagenic. They cause mutations. We're damaging DNA, but we're just hoping that we can have the maximum impact on the rapidly dividing cancer cells and less impact on healthy cells that hopefully have their repair characteristics intact. Okay, so just kind of a quick comment on that. This is why, though, chemotherapeutic agents like that are dealt with so carefully by the practitioners, because they're dangerous. Okay, radiation, just quickly here. So you go out in the sun, okay, you get exposed to UV, kind of soft radiation, okay. What usual consequence of that? Something we call the pyrimidine dimers. So nucleotide bases in DNA, you've got purines and pyrimidines. Okay, pyrimidines can form covalent bonds with there's an external pyrimidine that can form a covalent bond with it. called a permitting dimer, prevents DNA replication or interferes with DNA replication. Okay? Fortunately, our repair systems get to most of those, but they won't get to all of them, which is why some exposures are good. Hard radiation, X-rays, gamma rays, etc. A lot of what they tend to do is ionize molecules in the cell. And as a consequence of that, that will cause one of two things. So DNA breaks are common, double-strand breaks, which are the worst type of DNA damage. Or methylation can be another consequence. Okay? So ionization of molecules near the DNA attacks the DNA, causes damage, either in the form of breaks or methylation. Or in some cases, and as a consequence of breaks, just to the side, you can get things like translocations and things like that. It also has the effect of inhibiting cell-mediated immunity. And so our own surveillance systems do a poorer job of identifying tumors under that situation. Okay. Let's just go over there one more. Okay, we're getting there. Okay, viruses. Okay, so some of the big players here, so human papillomavirus, HPV. Okay, it's kind of one of the big players here. Hepatitis B, heart-present sarcoma, others, hepatitis C. Okay, these have been kind of broken down as to what the nature of their nucleic acid material. So we're going to largely kind of focus on HPV because it's such an important contributor to cancer in worldwide. There's basically at least 70 different strains of HPV. Now there's some big players in terms of cancer, so we've been able to kind of focus our attention in terms of building vaccines against them. But we're not all the way there yet. So basically types 1, 2, 4, and 7 cause genital warts. Type 16 and 17 cause squamous carcinoma, cervix, anus, and oral cancers as well. And it most certainly is a sexually transmitted cancer. Okay. And frankly, the vaccines are very effective against it. Okay, so it is the statistics on it, like I say, are roughly 35,000 cases of cervical cancer every year in the United States. Okay, and of those, we haven't, our vaccines, Gardasil, etc., are not perfect yet. But we cover probably 90% of that, you know, somewhere between 29,000 and 30,000, something like that. Of those cases could be prevented with routine vaccination. Not to moralize or anything, but you know, getting uniform vaccination would be very helpful. Again, not to moralize, but I've got well, he's now about to turn 16, but when he turned 13-year-old son, got him vaccinated, you know, kind of at the point where before I was expecting him to be active sexually, just because it protects him, but it also protects his partners. And at least he can't act as a vehicle or as a vector for transmitting HPV. From a mechanistic perspective, okay, so HPV, there's a couple of HPV proteins that we're kind of interested in. So E6 and E7. So E6 inhibits P53. Okay. So expressing that protein is akin to losing both copies of P53, your tumor suppressor. Okay? HPV E7 also inhibits P53. If you remember from my little cartoon showing the diagram of how P53 worked through enhancing, amongst one of the things it did was enhance the production of P21. P21 is also inhibited. Okay? RB, so retinoblastoma, is also inhibited, and it's involved in growth and rest. And so basically this hits us in a number of different ways that kind of converge on that kind of P53 kind of pathway that we looked at earlier. Okay? So it's definitely a case where, you know, frankly, encouraging routine vaccination is something that could really be done. To me, it's just rather appalling that there's 35,000 cases of vaccine-preventable cancer every year. And you know, when you consider that, take that as a decade instead. That's 350,000. Okay. Inheritance. So inheritance is like actually the smaller piece of the puzzle in terms of mutations overall. So like I said, the current estimate is probably a 30% contribution. Okay, some of the players that you would be familiar with, so BRCA. Okay, so BRCA 1 and 2, or BRCA 1 and 2, okay, are actually only responsible for ballpark about 10% of cancers. Sorry, it's so small. It's just yeah, sorry. Next time I'll take them in like proper bigger or something. Anyway, so BRCA 1 and 2 account for about 10% of breast cancers. Okay. However, people that inherit two defective copies have a 60 to 80% chance of having breast cancer in their lifetime. So someone who has inherited that from their parents has essentially kind of, you wouldn't want to bet against it. And that's why preventative mastectomy may be a desired option for people who are in that situation. And them being aware of the genetics and genetic testing can be real helpful. So where there's a family history of breast cancer and one would suspect that, then it could be worth testing. Because frankly, a 60 to 80% chance of breast cancer alone and a tenfold higher elevated or tenfold higher chance of ovarian cancer, it's not much to see collected. Most of the other players, again, so APC is a player in there, and they mentioned it partway through, so the familial adenomatosis polyposis coli. People who are born with two defective copies of APC, frankly, usually what's happened is the colon is removed, and they are forced to use colostomy for the rest of their lives, because it is almost invariable that they're going to have colon cancer. So there are a few cases like that, but like I say, by and large, these are still numerically far fewer than the sporadic cases. Okay, a quick comment on, I just want to catch up where I am. Just getting to where I was, okay. I want to comment quickly about tumor markers. They're going to be, in your professional career as PAs, you're going to see this expand radically. There's already methodologies out there that allow you to detect tumor proteins in blood samples, or in fecal samples, or things like that. So things like Cologuard, which looks for DNA markers in fecal samples. There's also something called CancerSeq that can use a routine blood test to look for commonly occurring sort of biomarkers of cancer. Those are going to become more and more important to you guys as clinicians. I just wanted to point out a couple things here on this table, kind of selected tumor markers. So the first is PSA. So prostate-specific antigen. It's a terrible marker, okay? Honestly, its main use, it indicates that there is some sort of hyperplasia in the prostate. But that, you could just have benign hypertrophy, okay? So it's not a good indicator of the fact that the person has prostate cancer. All it really is suggests the need for additional testing. It is also useful as a biomarker for looking at response to treatment, because what is true is if someone has prostate cancer and you are treating them, you can use it as a marker for improvement of the cancer, because you expect it to drop over time. Okay, so it's useful from that perspective. I wanted to also point out the fact that there's these newer molecular markers. So the tests that can analyze Cologuard. So you can take a roughly $50 test that you can take, collect a fecal sample at home, send it in the mail. For roughly $50, you get pretty much the same diagnostic value or same detection value as you would with a, let's say, roughly $1,000 colonoscopy. And so that's going to become increasingly important. And like I said, you're going to see more of these tests where we're able to take routine blood work and detect cancer markers in it, whether it's cancer, mutant cancer genes in the DNA, or cancer proteins that are present in the bloodstream. And so that's going to become increasingly important for you guys as clinicians. Okay, last part of this is in some ways some of the most important. Okay, is staging. Okay, what we're trying to do here is, as clinicians, is you are trying to figure out to what extent the cancer has progressed and give it a stage. is generally given kind of a stage 1 through 4, but there's also a specific terminology that goes throughout for it. So the mandatory parameters here are T, N, and M. So T is the tumor, okay, basically the size of the tumor. And so it's the size or direct extent of the tumor. And so T1 through 4 is basically size and how much it's spread. T0 means, of course, there's no sign of a tumor. You could have a tumor in situ for carcinoma in situ, or TIS for carcinoma in situ. Tumor cannot be evaluated, or some of the parameters there. So really, it's the size of the tumor, is what you're really looking at. N is lymphatic system, so lymph nodes, N for nodes, okay? So you get a situation where you can evaluate it, and then you have N0 through 3. And it's, again, the extent of spread to the local lymphatics, or more broadly. M is metastasis. Makes sense. Okay, so if you cannot evaluate, that's one possibility. And then it's either 0 or 1 in general terms. Okay, so no distant metastasis versus metastasis to distant organs, excuse me. Okay, these are the basic parameters that staging will be based on. Okay, so you could describe a tumor as, so for example, T2, N0, M0, okay, something like that, or T1, M0, N0, M0, okay. That would give you a low cancer stage, which would give you, a more promising outcome in terms of the prognosis for the patient. Higher values in terms of the size, or certainly metastasis, would be associated with less favorable outcomes. I want you to know this stuff, okay, and the next slide as well, okay, because I will make up questions on this. Okay, so there's other parameters as well. Okay, these are non-mandatory parameters that can be considered. So grade, okay? Grade is basically how well differentiated the cells appear. Well differentiated is good from a prognosis perspective, okay? So well differentiated cells mean low grade cancer, okay? So low G values, okay? So the cells look like the cells from the tissue they were derived. They look like fat cells, they look like muscle cells or skin cells, okay? High grade cells, okay, means they've lost that characteristic differentiated appearance. They don't look like the cells they were derived from. Okay. So instead of a lipoma, you have a liposarcoma. Okay? Much worse. Okay? R. Okay, so refers to resection. Okay? So obviously, in many cases, surgery is the primary mode of treatment. Colon cancer, it's definitely for low-stage colon cancers. Removal of the tumor may be your only therapeutic option. Okay, it depends on how completely and how carefully you are able to remove it. If you have clear boundaries. So, for example, once the surgical sample has been obtained, then a histopathologist will look at it and make a determination as to whether there are margins of healthy tissue surrounding the whole of the tumor. That's a good thing. Okay? When you're not able to do that as cleanly, then obviously that's associated with the need for further treatment, chemotherapy, what have you. Okay? L can be used as invasion of lymphatic vessels. V is invasion into veins. Okay? C is a modifier of certainty. So it gives you a fudge factor. Okay? Are we certain here or not? Okay? Of the last mentioned parameter. Okay? Now you also have prefix modifiers. Okay? So C means that you just got it from essentially a clinical examination of the patient, as opposed to the P prefix, which basically means that you looked at the surgical sample. Okay? So in other words, it's an indication where you got your data from. Why? Okay, neoadjuvant therapy. When you guys get into therapeutic options, you'll hear more about this down the road. There are some times when you need to debulk a tumor before you intercede surgically. Okay? Debulking could be from chemotherapy or radiation therapy or whatever. Okay? You're trying to debulk the tumor to make surgery easier to do. Okay? And so you may assess where the tumor's at after you've applied that intervention before you do the surgery to know where you stand. Okay. And then I won't kind of belabor the examples here, but you should kind of go through them and make sure you kind of understand how the nomenclature is being applied. Okay? Well, that staging is going to be very important to you. Obviously, low stages, stage 1, best value. So stage 1 are curable. Well, stage 4, you're considering palliative care, frankly. Okay.
So when someone says like stage 1, what particular parameters?
Generally, well, it's going to reflect a kind of a cumulative, but it's going to be a small tumor, and generally stage 1 are small tumor, no spread to lymphatics, no metastasis. Okay.
So it's kind of like an average.
It's taking into account those low values. There are specific criteria, but yeah.
So for the other parameters where it says C, is that just subjective, like the physician gets to?
It's
Okay.
a fudge factor.
Okay.
Yeah, they get to basically, because to some extent you're, okay, so where did your data come from, for example, things like that.
Okay.
Absolutely. Anything else from you guys? Any other questions? My goodness, I actually managed to finish on time. My students will tell you, Destiny can tell you, or Brianna can tell you, that is like, it's like.
It's impressive.
She doesn't have to be nice to me anymore because she's a PA. Her and PA school. But anyway, I appreciate your attention, guys, and I hope you found that interesting and informative.
Thank you.